And we might as well get started. We'll see if a few more people join in shortly. All right. Just going to close a few things. Okay. Oh, the slides look really nice, Margaret. Well, welcome everyone and hello. It's great to have you here today at our Colloquium event at the Center for Research on Personhood and Dementia, which is located at UBC. And on behalf of the center's co-directors, Drs. Deborah O'Connor and Dr. Alison Finney, welcome to all of you. My name is Mariko Sakamoto. I think I know most of you, and if I don't, happy to meet you here in this venue. I'm a research affiliate at the center and the knowledge translation coordinator there, and I'm going to be facilitating this event. So we're all joining online, obviously, and we're likely finding ourselves on different lands and territories. But this is a research center at UBC at the Point Grey campus. And as such, I really want to take a moment to acknowledge that UBC is on the traditional, unceded, and ancestral territory of the Musqueam First Nation. And I just want to pause for a moment so that we can all reflect on where we're joining from today and from which lands we're situated on. I also want to welcome our speaker this afternoon, Margaret Lin. So great to have you here, Margaret. As I mentioned to many of you as you were joining in, Margaret is in Japan right now, where it's 9 a.m. in the morning. Margaret's a registered nurse and a project lead coordinating the social prescribing program and various regional frailty prevention and healthy aging projects in the Fraser Health Authority. She's passionate about empowering older folks, families, and care providers, as well as supporting quality of life. She feels grateful to facilitate collaborations between all of these groups, and she really enjoys bringing people together. And you'll really see that when Margaret speaks. She's a lovely speaker and is really passionate about the work she does. What's also exciting about Margaret is that she's starting a PhD in nursing this September at the University of British Columbia. So that's really exciting news, Margaret. And she's excited. She's told me she's excited to be continuing to explore topics around ideas of social prescribing, as well as collaboration between healthcare and community, all with the goal of supporting older people. And as you can see on the slide, she's going to be discussing social prescribing, specifically how it is a healthcare community collaboration to support quality of life for older people, including those living with dementia. We also have Alison Finney here today. She's got her video off because the internet's acting a bit funny, but she's also very happy to be welcoming all of you. So thanks, Alison, for that message in the chat. Margaret, I'm going to turn it over to you.
Okay, thank you, Mariko, and good morning, everyone, from this time, and good evening on your time. My name is Margaret, and thank you for Mariko's very warm introduction. And I hope you can hear me okay. If at any time I pause or am not too clear, please let me know, because I'm in a public area and I don't want to disturb too many people. So I'm very excited today to talk with you about social prescribing. And I see many familiar faces and names actually today, so I feel like I'm at home. So please, during the presentation at any moment, please feel free to unmute, raise questions, or interrupt me. It's all good. I love that. So happy to start this conversation with you. So today, as you can see, we're going to talk about social prescribing. And I think some of you know me through more Vancouver Coastal Health, but today I'm representing Fraser Health Authority. So really, this is a healthcare and community collaboration to support quality of life. And before I go forward, I'm going to acknowledge that although I'm not on the land of Canada today, but I'm really thankful that social prescribing can take place on the people every day on the traditional, ancestral, and the ancestral shared territories of all of these amazing groups. So the Kwantlen, Coquitlam, I never say that correctly, Coquitlam, sorry, Semiahmoo, and Swaziland First Nations. So mostly we're focused on kind of the social prescribing initiatives in BC and Fraser Health today. So starting with a little picture, it's not the biggest, but this is a prescription. So many of you might have already seen this on the internet, but it prescribed from a doctor, puppy of choice, with walks twice daily and lots of love. So I imagine, well, personally, that is a prescription I would love. But imagine if there could be many more prescriptions like this. What a beautiful world that would be. And I'm not quoting lyrics. So it could be quite amazing. And today we're going to show you and discuss a bit about what has been happening in BC so far. So to start, what is social prescribing? So if we look into a definition that was kind of newly created recently, it's a means of trusted individuals in either clinical or community settings, and they identify someone that has non-medical or health-related social needs, so not medical needs, and they basically connect them with non-clinical support and services within their community. And that is by co-producing a social prescription. So social prescription, as you will see very soon, it takes place in many different forms, different scales, different styles. And today we'll see some of those. So in terms of where it is happening, although the term itself is fairly new-ish compared to the world's history, but we know it has been happening, just not called that name. But in terms of the word itself, it did originated in UK. And now it has become part of the NHS long-term plan, which is very exciting. And as far as data goes, we're aware that it's now happening in 24 different countries. And every countries, again, they do it differently, involve different people and different scales. So now if we narrow it down a little bit, if we go to Canada, so it is happening in several provinces. Either it could be regional level or organizational level. And what happened last year that was quite exciting is the Canadian Institute for Social Prescribing, which is an organization funded by Red Cross, actually. And they wanted to bring together all the initiatives discussing and exploring social prescribing in Canada. So that's quite a milestone. And that happened last year. And if you're a student, they also have a student collective, if that's something you're interested in. And in BC and Alberta specifically, it's funded by the Provincial Ministry of Health. So it's a funding from them. So now if we go down a bit more further, in BC, as we mentioned, it's currently funded year to year. So it's not a 10-year program or anything yet, which we hope it will become. But currently is 1 year, and then so on. And it's funded by Ministry of Health. And the funding was coordinated through United Way BC, where United Way BC then collaborated with 19 different local community organizations to develop a program called Social Prescribing. And why am I here today? Although I'm not with United Way, I'm not with a community organization per se, but I'm with Fraser Health, is because since the very beginning, we have been able to have a team and designated team members to support this integration in healthcare and to explore what it will look like. So this is a very brief overview of where it is happening, and we're going to dive deeper in the next few slides. So this is what it is in the graph form. So this is in BC. So essentially is the healthcare providers, they can refer older adults, 65-year-old or plus at the moment, to someone called a seniors community connector. And the seniors community connector, we have 19 of them. They belong to each of the community organization. And from there on, this connector is going to do an intake and a tailored wellness plan and connect the older adults or the clients or their families to community resources. For example, it could be meal delivery services, it could be dietitian services in the community, it could be social activities, social outings in their community, it could be physical activities and the ones, of course, suitable for the client's need and preferences. They could be helping with arranging transportation, volunteer drivers, handy-dart applications, for example. They could be supporting with housing navigation, which is known as a big crisis in BC. Or sometimes if they notice that there is actually a healthcare need that needs to go back to the healthcare team, then they would, of course, collaborate with the existing healthcare teams. So what you'll see here, the last step is actually quite important because it's not just a one-time thing. It's not just that, okay, the client goes see the connector and they have a plan and then they say bye. It's actually a continuous process where they develop the plan together and they modify it together. The connector will check in with the client to see how's everything going. Did that plan work out? Is there any barrier, any things you're concerned of, anything we should look into together? And they do that collaboratively. And you'll see there the third party is the healthcare providers. So we're trying to improve that process of how the community connectors, so in the community sector, how can they relate back to the healthcare providers and the healthcare teams so it can be a even more holistic healthcare plan, because we know healthcare is not just medical. So that is what social prescribing is in a graph form. And you'll see here on the bottom left, we added a few notes. These are a few examples of where we have social prescribing rolled out in the Fraser Health region, at least. So when we say rolled out, we mean we have a team that goes to each of the teams, hospitals, clinics, care providers, and just explain to them what is social prescribing, how can you refer, how can it help your clients, etc. And then make sure they have the proper way to refer and refer the right clients. So in outside of Fraser Health, I can't comment as much, but we do try our best as well to encourage further collaborations that way. But this is what it has been so far. And I'm going to touch a bit more on that and how you can help with this process as well. So now back to this connector person that we kept talking about. So throughout BC, there are 19 different seniors community connectors. In Fraser Health, there are 10. In Vancouver Coastal Health regions, there are about 5. We have 2 on the island, I believe, and 2 interior, if my math is correct. But we have 19 in total. And they are hired by their local community organization. So they are not healthcare providers. For example, in Surrey, it's quite a big one, and they are organized by diversity, and they have a social prescribing program. And what they do is they support clients in their community. So for example, even though today someone might be in Chilliwack General Hospital, but they're from Langley, they would go to the Langley connector. And they're passionate about supporting older adults and motivational interviewing. And that's what they all share, is just a lot of love and knowledge. And they're very knowledgeable expert of their local community resources. In terms of background, which we get that question a lot, they have really a diverse background. Some of them are new grad social workers, some of them are retired social worker. A lot of them were nurses before, a lot of them are long-term volunteers in their community. So never in healthcare, but just long-term in community, and they know the community inside and out. So they could come from many, many backgrounds, but they do share a lot of love and passion for this program. So I brought 2 stories here today, but before I move on, I wonder, does anyone have any questions about anything we've mentioned already?
Margaret, there's a question in the chat from Myrna,
Yes.
and it's about not being technically able, and whether it would create a lesson service. Myrna, did you want to elaborate on that question a wee bit?
I deal with a lot of seniors who do not have computers nor even wish to have computers. And I know that we're in this computer society. So how does it work for folks without that kind of ability?
Right. So the social prescribing process itself doesn't really require technology at all. Very oftentimes it doesn't. So you can either be referred by a healthcare professional, which could be your family doctor and nurse practitioner, could be any social worker, home health nurse, for example. But oftentimes you can also self-refer, and that doesn't require a computer. We will talk about it later, but you can go through either BC 211, or people can visit the community organizations directly and ask about social prescribing. So it definitely, you don't need access to technology to know about this program. And that is what we are trying to promote as well. Having in physical posters, having it by word of mouth, doing in-person presentations in different communities, and just exploring different ways to spread the word out. And as far as technology goes, I don't think that impacts the referral as much at the moment. In terms of how social prescribing can support people without technology, I know that it definitely happens on a very frequent basis. Most of the time, the connectors connect by phone, or they do in-person check-ins. So there's nothing that they require Zoom or anything. So that really, really reduce the barriers. And oftentimes, if that needs does arise, for example, if they do want to contact peer support group that happens to be online, but they either don't have Wi-Fi, they don't have an electronic device. Oftentimes the connectors do explore that with the clients. So sometimes they will find kind of donated device or purchase reimbursed devices for the clients, or they also connect them with the local technical kind of technology support hotline, which I didn't know of until I started this job, and it's very exciting. So it's a very holistic plan. I think that's as far as I can share about technology. Does that kind of answer the question, Marina? Awesome. Thank
Yes,
you.
thank you very much.
Perfect. Thank you. Anything else in the chat? Sorry, I can't really see it well.
Yeah, there's one more, Margaret, from Joey. She's asking
Yes.
about the prescription and whether it's usually on a one-time basis, or will connectors will have follow-up meetings with the older adults in terms
Yeah.
of the prescription part.
Yeah, thank you, Joey. So it is definitely an ongoing basis. So and it depends on what the client needs. So we know that it's not like we have a 3 months together and then that's it. Some people, they might need 3 sessions just to develop a plan together and then build a bit of confidence, remove some barriers, and then they feel comfortable. Okay, yeah, I got this. I think I can navigate this myself. I think I can take on the programs and give it a try. But they're always reassured that they have the connector's number. So if at any time, even though they don't really connect anymore, they always have a number to call. And we know that that has been very significantly helpful just for someone to have a number, knowing that someone is out there. So that's one way. And we know for a lot of clients is much more long-term. So we know definitely 6 months, 6 months or sometimes a year. And it's not like they meet every month or anything, but it's based on their needs. So do they need this frequent check-ins, or can we let go a little bit and see how things go? And maybe we'll check in together in 3 months. So it really varies, but definitely not just one time. Hope that helps, Joy.
Thank you.
Thank
Clear.
you.
Margaret, would you like questions as you go, or would you like to keep the questions for the end? What do you prefer?
Both okay. I think, I think as we go is good. So we can be more like a discussion.
Okay, sounds great.
Yeah.
Thanks,
Yeah.
Margaret. That seems to be it for the questions for now.
Thank you, Mariko. And yeah, if it's anything that I will cover later on the slide, I'll mention it. So that's not a problem at all. Okay, so here are 2 stories. So the first one is this client, they went to the doctor and the doctor told them that they have dementia, which we know is a process that takes a long time to explore together and then receiving the diagnosis. So upon learning that, the client, and this is a real story, all of these are real stories. So the client's main concern is about her driver license. So she has heard that maybe down the road, she wouldn't be able to hold her driver license anymore. And then what would happen from there on? So she expressed this concern to her doctor. We know that oftentimes it doesn't happen in all that one session because it's a lot to take in. But for this client, she was able to mention that concern. And then from there on, the doctor mentioned, how about connecting with social prescribing, connecting with a connector, and let's see how it goes. So that's indeed what happened. The doctor helped made a referral to the seniors community connector. And from there on, the client and the connectors connected. So what happened first is, of course, the client's main concern was transportation. So what would I do if I don't have my driver license anymore? So they worked on a handy dart applications together in the future in case the license becomes a concern. And then upon further exploration, they also realized, actually some lighthouse keeping would also help. So that was not originally mentioned by the doctor, but because usually they have about 30 minutes, 1 hour, really collaborative discussions together, the connectors was able to identify that. So they recognize, okay, let's help you set up with some lighthouse keeping to start. And then upon more chatting, which is we know chatting is fun, we realized that, okay, actually there might be some needs of proper kinds of groceries or grocery and meal deliveries. So the client doesn't have to head out too often. But of course, depending on what they need and what they prefer and the frequency that suits them the best. So they also set up some grocery delivery services there.
And also the client would like to meet more people and become more involved in the community. So the connectors also sign up the client with several social outings in her communities. And I believe one of them is a volunteer opportunity. And that's one of the stigma that we might talk about soon, is oftentimes people assume older adults receive resources, but that's not always the case, right? They are active participants in their community and they can contribute so much to the community. And social prescribing can be one of the process that encourage that. So we know that for this client, they were also connected back with different social outings and also volunteer opportunities. So other than that, upon more chatting, I didn't know how long this conversation was, but it seems like a good one. So upon further chatting, they also help sign up the client with some physical activities that suits her need and mobility status. And also the connector referred the client to Alzheimer's Society of BC, which I think I see Sarah here today. But they share with her resources from the Alzheimer's Society of BC, so the client can learn more about that. So as you can see, it started with one thing about us worrying about driver license, and then it led to a very holistic plan that addresses the client's need and for down the road as well. So this is one example. The other example, this is in word form, because we know everyone learned differently, but let's see. So we have Emily, who was referred to the program by her family member, so not by a provider, but family member. And she was referred because she feels isolated and she wants some more social connection. So again, they meet with the connector and they found out that, oh, actually, in addition to social connection, she is actually comfortable with using technology, but her computer broke and she couldn't really afford to get it fixed. And then she also found out Emily's hard of hearing and couldn't really afford a hearing aid. So this kind of taps into, Myrna, the question you were asking before about technology. So then what happens upon identifying these concerns is the connectors connected Emily with community organizations for social outings. Again, there's so many social outings, it seems very fun. And the connector secured Emily with an almost new iPad, and oftentimes it's from donations in the community and from very kind volunteers as well, and connected her with a tech support community program that Emily can call whenever she might need some help with technology. And the connectors also help set up a free vision and hearing test and also a free hearing aid for Emily. And that is because the connector partnered with her local clinics, and the clinics was very kind to offer this collaboration. And the last but not least thing that they did together was the connector helped Emily connect with the organization for physical activities. And the recreation pass oftentimes can also become a barrier. So in this case, very fortunately, Emily was able to have a program that helped reimburse her for the annual recreation fee of $30. So this is another type of social prescribing or example, but as we can tell from both stories, they're quite holistic. They're very exploring process. And it could go in many, many different directions. So as we can see, it is person-centered, it is strength-based, and it is team-based as well. So it's not a one-person thing. It's not that I tell you, I think you need this, and then I prescribe you this. It's not that. It's us collaborating together and discussing what we need. And what I really like from the connector is they always, as we mentioned before, they really emphasize on the autonomy of the client. So they know that they're not the crutches forever. They don't want to be someone that continues to support them and then they gradually lose their autonomy. They don't want to be that person. They want to be someone that empowers the older adult and their family members so they can continue to become involved and they can remove the barriers that might be preventing them from navigating more resources. So this is not a PR, I swear, but just want to highlight a few things that how we have been trying to help make this happen. Although it's more of a community collaboration, we know that it reaches much more beyond community, and the healthcare teams are actually very excited and they all want to learn about social prescribing. So we're very fortunate to be able to support that. So what I do and my team does is we educate the different healthcare providers and leadership teams about social prescribing and how we can refer clients and how it helps. We also support the connectors. So we regularly meet with the connectors and
teaching them about the healthcare system. What does the physiotherapy do? What does the occupational therapy do? Because they all refer to social prescribing. And we also trying to understand and standardize the material and the strategies to support their referrals, to develop education materials, promotional materials, and how do we sustain this program? Because we don't want it to just be 1 year, we want it to continue. So how do we do that? And so that could be by evaluating how the program works, to do quality improvements as well. There's a lot of that. And we also hope to connect people together. So who else might be interested in social prescribing? Who else can support social prescribing? And we help facilitate the collaboration and connection, which is kind of like what we're doing today. And we're also brainstorming different ways of how we can integrate social prescribing with other existing programs. For example, the first link in Alzheimer's Society of BC. I know, Sarah, we have more to chat about on how we can integrate those two together. There's many other programs for caregivers, for example. They also have a coordinator that does similar to social prescribing. So how we can make these all programs all work together. And also to promote healthcare and community collaborations, showing people that it does make a difference if we talk with each other instead of working in silos. So several ways how we are helping. To kind of highlight it a bit more about on dementia, how we are trying to address dementia and recognizing it. So one is through education. So we realize and we learn from our connectors that they're receiving a lot of referrals with clients with dementia. And regardless of capacity or skills or what the cases are like, the connectors did express that, I'm not too sure if I can support this client as best as I can. I would like to learn more. So that's what really prompted our initial collaboration with Alzheimer's Society of BC. And so far they have one webinar on dementia, and we're hoping to have more on case studies and how the different strategies, and probably flipping the stigma will become a tool there, but how we can support the connectors so they can support the older adults and their families much better. And also we have dementia webinars upcoming for healthcare providers and Fraser Health as well. So many ways that we hope to collaborate. And the second thing that we try to do is try to address the stigma. So how can we be mindful of people with dementia and their family, their autonomy and their diversity as well? So one of the ways we're doing that is when we go to the different teams and talk about social prescribing, we usually have to kind of explain to them the different stories and criteria. And we also have to write criteria for social prescribing. So clients who are suitable for social prescribing, we have to write that out on the referral form so it's clear for the healthcare providers. And it took us a while to balance how do we make sure it's the right criteria without putting a label to anyone. So we know the connectors they kind of require clients who can do that active wellness planning and be able to follow up and kind of remember the phone calls, or at least have someone to support them or prompt them to continue that planning piece, because that's one of the biggest pieces in social prescribing. So for clients that might not be able to do that, then social prescribing might not be the most suitable for them. So there are barriers and limitations, but how can we word that properly on the referral form so it makes sense, and it also doesn't introduce stigma. So what we ended up putting right now on the referral form is we have a checkbox and says the client to have willingness and ability to have ongoing care planning. So we do that because a lot of the time the healthcare providers ask us directly, if my clients have dementia, does that mean they cannot get referred to social prescribing? Which is not true, because we know that people, whether they have dementia or they have other diagnoses or symptoms or things going on in life, it doesn't mean that they cannot actively participate. So we always have to phrase it very properly, I think, or at least we try to phrase it properly, and trying to adapt and collaborate and figure out a way that can be as inclusive as possible, but also the right messages. So that's one of the ways that we try to address that. And third is recognizing the importance of dementia in general and how can we empower people through collaboration. So what has been very exciting is, as of about 3 weeks ago, We know that the Fraser Health OKR, so like the health organization strategy plan and all of that, they officially recognizes frailty and dementia as two things, the big strategies that we need to focus on. So this means the executive team, they're recognizing, yes, we need to catch people before they become frail. We need to recognize healthcare and community collaboration is important. We need to make sure these collaborative initiatives move on and continue to have resources. So that's quite exciting. So recognizing that important. And we also have a project coming on, well, not coming on, it has already been happening. It's called Pacific Regional Center for Healthy Aging. And that is essentially a cross BC collaboration where we're working with now hopefully all the universities and health authorities in BC to really create a knowledge hub for people so they can learn about healthy aging, so it can be practical. And then the text, so like the text on what is aging and things related to that, and the resources can be integrated in one place. So it's not meant to replace any amazing websites currently, like AgeWell has a great website, Alzheimer's Society of BC has a great website, the Ministry of Health has a great website, but how do we make this together so it's easier for people to navigate? So things like that. It's another way that we're trying to address that. And dementia is definitely a topic that we want to bring up and discuss together. So those are different ways of how we're addressing dementia specifically. But we know that there's also many things upcoming. There's many things we need to do. We need to help raise awareness, just kind of like what we're doing today and going to different conferences. We need a lot of evaluation and research involved for social prescribing to really show how has social prescribing helped, or how can social prescribing help? And also how can we standardize the process of social prescribing and making sure all the connectors have the training that supports them in supporting their community. And how can we help build the capacity for people in healthcare and for people in community, knowing that it's not a one-side thing. It's not that, yes, healthcare, we can just dump a lot of people into the community and community will take care of that. It's not supposed to be like that. We're supposed to work together and then make sure we figure out a model together. So that's what I mean by building capacity. And exploring different ways of collaboration, which we talked about. And another main thing we're trying to do is engaging students and community members, either in becoming advocates or becoming volunteers for social prescribing. So many things ongoing, and we hope to keep on going. So all of these hopefully will lead to continuous program funding, so beyond the 1 year, and we can have more seniors community connectors, and there'll be more well-equipped, although they are already, but there's always more things to learn and to explore together, and also to have more community resources, because we know in the community as well, the resources are very, very tapped out. So how can we build capacity together is what we always try to work on. And now how can you help, which is very exciting. I hope this is a slide you have been waiting for. But essentially if you could help identifying the non-medical needs, either if you're a healthcare provider with your clients, or if you are not a healthcare provider, just with your friends and families and your neighbors, really. I have heard a lot of clients who referred their neighbor, which is amazing. So once you do, consider social prescribing or BC211. Or there's another website called pathwaysbc.ca, which is also a website to help navigate resources. But today we'll talk more about BC211, because I think, in my personal opinion, it's a bit easier to use and more broadly covered. So start exploring what's out there in your community, because there are really tons of things in the community, and I still keep learning every day. And share the stories. We have amazing stories. For example, Emily's stories is written into an article. Share the stories if you find that resonates with you. Share the knowledge you learned today. Share the resources that you heard about today with your teams, with your colleagues, your communities, your families. And we also have posters and pamphlets that are ready to print, that's publicly available. And we're trying to have it available in grocery stores and casinos and community centers, rec centers, just having it anywhere so people can learn that there's something called social prescribing and called BC211. So we do have those, but we need your help to really spread it out. Or you could also become a volunteer, so, which is much needed, either for social prescribing or for any of the community program.
And I'll be happy to show you where to sign up or connect you with someone. So become a volunteer. And if none of the above, you can help advocate that there needs to be more collaboration between healthcare community, which is hopefully what you're here today. If not, then hopefully it has interest you by now after 37 minutes. So there are many, many ways you can help, and we do have the resource to support you with that. So happy to share anything. And this is how, oh, thank you, Marta. And this is how you can help in a graph form. So once we start identifying, there are some non-clinical needs, I would recommend two pathways. So one, if it's someone who can make that phone call themselves or can connect to a program, BC 211 is a great resource to go. And we do have a pamphlet, so you don't have to memorize any of these. But it's essentially a number similar to 811, but 811 is for healthcare. So 211 is for any community and non-clinical resources. So for example, I have called 211 for my neighbor asking about technology, helping them get a device that's suitable for them, and tech support. So I asked 211 like, hey, I live in South Surrey, White Rock. I'm calling for my neighbor. I'm looking for this, and they have these need and these concerns. What is out there? What is out there? And essentially 211 has a real person, so not robot. They have a real person navigator who will mention, yes, so in South Surrey, White Rock, there are these programs that might suit your needs. This is their phone number, this is their contact, or these are a few other ones that you can explore that's provincial wide. So there are many, many things they offered me. And what I find the most helpful is in the end, they texted me all the things. So I didn't have to write them down. They texted me all the things that they talked about. And then I could also call them back anytime. So you can reach 211 by either call to talk with a navigator or by text, or there's also a BC 211 website that you can help navigate and type in keywords if that's what you prefer. But what's also amazing about 211 is they are 24/7. They offer, I think, what is the number now? 235 languages. So the navigator, yeah, it's quite amazing. But the navigator will make sure to connect with the interpreter and have a three-way talk if that is needed. So that's 211. So that's for any age, not just older adults. So that's for anyone to call to explore any types of community resources. But you will have to have the ability, once you have that list, to further call and make that actual connection. So on the other end, social prescribing provide that tailored wellness planning and have the connector to kind of do that connection with you. So because it involves that continuous collaboration piece, it does require a consent. So if you're a healthcare provider, definitely talk with your clients first, please, before you make a referral. If you're a family member, a friend, a neighbor, just let people know, let people know that you're considering this, and they can either refer themselves or you can refer with them together. So don't just refer someone without telling them. That's the main message. But there are also pamphlets to support you learning about it, what it is, just a very brief one. And there are many ways people can be referred. Either they can call 211 and ask for that program, or if if you are a Fraser healthcare provider, it's on Pulse, and you can just type social prescribing. And if you're a healthcare provider in other areas, you could either go 211, or you can go on pathwaysbc.ca, and all the communities programs should be on there. So social prescribing, again, is for people who really need that tailored wellness planning to remove some barriers, to build confidence, which we know is a big thing after COVID, or to really have a step-by-step plan. So there are two methods I would encourage you to take home and think about. And this is, again, just a pamphlet about 211 that we hope to share with many, many people with your help. But again, this talks about how it's 24/7, and this is the cover page mentioning different resources it can support. And on the inside, it provides some examples, because oftentimes when we say community resources, people are like, what do you mean by community resources? So these are just a few examples. So of course, the 211 navigator doesn't guarantee you access to these resources, but they can provide you info on some of these or even more. So this is the pamphlet, and that is actually it for now. And these are not the most friendly because they're QR code, but if needed, I can definitely send Mariko the links for all of these instead.
Thank you.
Thanks so much, Margaret. That was a great presentation. I really liked how you had the sections on how you can help and what you need to know. There's quite a few questions in the chat, which is great. And we also encourage live questions as well. But if you want to ask a question yourself, please just turn your mic on and speak out, or put the hand up function in the Zoom meeting. But Margaret, maybe I'll just bring your attention to some of the questions in the chat while we wait to see if we have any other questions from folks here today. I'm just going to go right back up because I think Myrna, you started us off again when you asked about the connector. I think you're asking about finding a good match between connectors. Your question was that having a female connector visiting a male could sometimes be challenging for the connector. Was there anything else you wanted to add to that question, Myrna?
I do know somebody that is a connector already in Maple Ridge, and I understood that sometimes a female connector going to see a male can be very troublesome. She was telling me the story of the male who just refuses to cover himself. So how do we get around that kind of situation that's so uncomfortable?
Thank you, Myrna. And it's so great to learn that you are in connection with Sandy. So yes, Sandy has also told me the story, and it's very traumatizing. I can imagine, and we know it's not just one case. So how can we hope to prevent that? And often it's not only just a sex and gender thing, right? It can happen many different cases. I think she also mentioned how there was a client with previous suicide ideation and she did not know until further exploration. There's a lot of mental health concerns there, or a lot of other things. For example, if people live in group housing and then they live with 2 other roommates or many other family members, that they might not welcome someone to visit the home. So things like that. So there are many things that does need addressing and to be aware of. So I remember what I talked with the connector and also brought up with fellow connectors as well, is we're trying to kind of set that boundaries. So as we kind of talked so far, there's not much manual or standardization or, like policy protocols, anything like that for social prescribing at all right now. Those are in development. So those are the things that needs addressing. So one of the big thing that came first was actually, risk identification. So in community, if you're a community health nurse or a community healthcare provider, there is this little template that before you visit someone's house, especially, that you perform and you recognize whether, is this a safe situation? Is it something I should prepare for, etc. But in the community, we know it's not that widespread. We know some programs have it, but social prescribing currently doesn't have it. And each of the connectors kind of does their own initiative and create their own way. So what we try to do is we try to share a simplified version from the community health team, which we asked, and then they shared, and then to share with each of the connectors and to say, here are some examples and templates, please develop it as it works for you, because we don't own these and we're not supposed to tell them, this is how you should do things, but we want to provide guides and resources so they can start developing things like that. So we know several of them has done that. They created like a little tick boxes every time when they take in the new clients, and then we built in that as well to identify those risks. So that is one way of preventing. It's not perfect, but it's something we try to do. And the other thing other than risk identification is through the different webinars that we're trying to plan. So what are the things that a connector should know to protect themselves and their clients? So that is an ongoing topic. We haven't had a webinar yet, so I can't say much, but that is something that we hope people can learn. And all of these needs, again, are identified by the connectors themselves. And we provide the support on whatever they might need and develop it together. And we're also working very closely with United Way BC to develop the provincial-wide kind of protocol and policy. So we are doing that. So one step at a time. Yeah.
That's excellent. Thank you so much.
Thank you, Lena.
Thanks for that question, Myrna. Thanks for that comprehensive answer, Margaret. That's great. Richard was asking in terms of volunteers, whether there are currently any advertisements or plans for recruitment in order to reach more people, really spread the word. I know you're making efforts with like these kinds of presentations to, let people know that there's opportunities for volunteers, but what are other ways that you're reaching out in terms of potential volunteers?
Yeah, so far, although it's electronically, but we do have a website that helps recruit volunteers. So each organization have their own website for volunteering and signing up. But we set up one so far only for Fraser Health Region though, but a page with all the volunteer coordinators contact that people can go to. And maybe later before we close, I can share that link. And you'll be able to go in there and see which community you want to volunteer for. And then there will be either the connector's email or the volunteer coordinator's email, which you can then reach out to them directly and explore kind of what their needs and process may be. Yeah, and thank you, Richard, for that question. Richard himself is a volunteer in Chilliwack.
Yeah, no, that was a good question, Richard. Did you have a follow-up for Margaret, Richard? No, okay. Paulina had, Myrna was asking about the kind of information people have to share. So if someone calls, especially the person themselves, do they have to give information like their PHN?
Yeah, so that was a big thing. Myrna, you ask amazing questions. Well, all of you do. PHN was a big thing because on the referral form, the connectors do usually collect them because they needed to help people sign up for different services, and it just helps them to have it on file. The initial barrier came from the healthcare providers. I'm not allowed to share that. And that's a risk management thing in the healthcare, but they're not allowed to share that. So on the referral form, we had to take that away. So it's not on there, but the connectors do usually call a client and ask for that. We know there are several cases which it becomes a bit difficult to acquire that. I think one example was the client was blind and they don't remember it. They need someone to read it off for them, and the connectors could not obtain that. And I think they did a creative approach, or I think the connector reached back to the healthcare provider that referred the client, and then to say, this is the way it goes. I have talked with the client, got the consent, the client's here. Can we have the personal health number? But I do, that is the number they hope to collect. Thank you, Myrna.
Yeah, thanks again, Myrna. Those are good questions in terms of how these things work. Paulina, Malcolm also had a good question. She was wondering about a wait time. So if someone is connected to a connector, does that happen right away, or how busy is it?
Yeah, it is busy, Paulina. Right now, so I would say in the Fraser Health region, because we have really ramped it up and then tell a lot of people about it. It's a bit tricky right now, the capacity is at max. So I would say the turnaround time from where the connector get the referral or when someone refer to the connector actually calling the client for the first time, it can range from 2 weeks, which is pretty good, to 8 weeks. So 2 to 8 weeks, that is a long time. So we had to kind of reshape our message as we recheck in with different teams to say, consider BC211 as well, make sure it's an appropriate referral. But even now that all the referrals the connectors said are quite appropriate, there's still too much because there are a lot of needs, but there are just one connector in each community. So yeah, 2 to 8 weeks for now, but it always fluctuates depending on which city you're in. And sometimes there's just no referral and sometimes there's tons of referral. So that's in the Fraser Health region. In the Vancouver Coastal Health region and like on the island or in the interior, we know that it's not as many referrals because the words are not as widespread yet as much that we hope to. So right now, I think they don't really have much of a wait time. So, yeah, great question. It is tapped out. So we do want to make sure it's sustainable and the connectors don't walk out on us and make sure they're supported as well.
So Margaret, it sounds like there are similar programs in some of the different health authorities, but just to clarify, it seems like from what you just said that they're not as popular yet. And is that because Fraser Health has done a really good job of getting the word out about this programming, or you've been doing it longer?
No, everyone started at the same time in about 2020, 2019, right before pandemic. So all the programs started at the same time, but I think the referral number is indeed because we have a designated team from the health authority and really kind of vouching for it, because we keep going around telling people about it, making sure there's a proper form, making it, delivering in a way that healthcare providers understand. So we really do see a big difference, and United Way is aware of that as well. So recently, myself and my colleague, Shannon, who's a fellow change lead, we start to support the other connectors outside of Fraser Health. But we can't support them as best as we can in Fraser Health because we do have our role there and our workload. But we do try to share everything we learn in Fraser Health. How do you talk with a healthcare provider? What is the message you can use? How do you spread the word? How do you reach out to a team? How can you reach out to clients? So we try to share all of those in like a knowledge package to all the connectors outside. But we do need more advocacy from the health authority at this moment. Anything helps.
Speaking of knowledge packages, Heather says, thanks for a wonderful presentation. And she's wondering if you have a digital version of the brochure and the pamphlets that she can share. And I think there were there some, did I see some QR codes at the end?
Yes, I do have some QR codes, but would it be easier if I post them in link format in the chat box?
That'd probably be great. Oh, I see, Heather, you've turned your camera on.
Sorry, yes. And I think I was typing that as you were showing, and I'm on my iPad, so I was typing it, and I think you were showing the QR code. So I didn't capture the QR codes, but if you could put just the links for the digital version, that would be great. Thanks, Margaret. That makes it easy for me to share with colleagues.
Yeah, for sure. Thank you, Heather. Great to see you.
And you.
That would be great. Deborah Sheets is saying, thank you, important program. And Jay Young had an interesting question about different ways programming like this could be used. Oh, Deborah, did you have anything else you wanted to add? I saw you turn your camera on there.
No, I didn't. Thanks for asking that. Great presentation. Thank you so much, Margaret.
Thanks, Margaret. Or thanks, thanks, Deborah. Wanted to catch you there when you turned your camera on. Jay Young's wondering if this kind of programming could be available for other patient populations. So maybe folks who aren't 65 and over, for maybe different types of reasons. And Jay Young, feel free to add to that question if you feel like it. But Margaret, what have you heard about this?
Yeah, so it has been a very commonly asked question, and we sure hope so, because right now the 65-year-old limit is put there because of the funding limitation from the Minister of Health, because it was meant to be a healthy aging initiative, and then they chose social prescribing as the way to do it. So that's why the age limit is there. But we know from rolling onto many different sites that a lot of the people, even let's not go to younger population, we just stay in adults. We know there's a lot of need for people who are in their early 50s, for example, or even late 40s, for example, because everyone can age differently and depending on their situation and depending on lifestyle and everything that happens in life. So we currently don't have that, but we sure hope in this, we can show how this model works, then there could be more funding. That's not just supporting older adults anymore, and it's supporting more population. And we know that's possible because in the East Coast, they do have social prescribing for students, and it's actually starting on campus. And that's something we're trying to do. I think I haven't told Joe yet, but I think we're seeing if we can have a BC chapter for social prescribing for students. So that's in the works. But this model would definitely work for other population as well. It's just where that funding will come from. So if we can advocate that and showing that there's a need, that would be great if everyone can benefit this. And one more example, I believe in UK, I think a lot of them uses taxi drivers. So it's not as kind of organization top down, it's very grassroots and from everywhere up. I believe their taxi drivers were given education courses that they can learn on how to do social prescribing. So when they have a client in their backseat, they can do that. And that's quite exciting. So there are many, many different ways to do it. Some are through collaboration with existing programs, some are with youth, especially, some are especially on art programs and physical activities. So tons of different ways to do it. It's just how we started. We'll need some funding or pilot and research.
That's really neat to hear about the taxi drivers. Julie had put in the chat, handy dart drivers could be trained in that kind of thing.
Yeah.
But it is kind of cool to hear about the grassroots movement in the UK in terms of taking it out of the healthcare system really into, people's cities and towns and the places they are. Margaret, you talked about funding, and there's been a couple of questions in the chat about funding. Earlier on, Alison Finney had asked about the Pacific Regional Center for Healthy Aging and who funds that. And Heather had found that it was the Canadian Frailty Network that funds that. But we'd be interested to hear more about funding, because Alison's asking that, it sounds like the ministry is funding this social prescription, but what's going on in Fraser Health in terms of what they're funding? I think that's what you're asking, Alison.
Yeah, it is. And you may have partly answered it because you said it's a healthy aging program in Fraser Health that's been funded. Is that right?
So are you meaning the social prescribing or the Pacific Regional Center for Healthy Aging?
The social prescribing.
Right. So I think Fraser Health funding currently comes from supporting our team. So it's from me and my colleagues, because our full-time role is mainly to promote social prescribing. So I think that it's more the human resource and then going into different teams and spreading that news. In terms of if they're funding in social prescribing in any way, there is one thing that we're exploring, how we can do social prescribing, not just with help from community. How can we do that in healthcare as well? Because a lot of the clients who might be more frail or need more also medical support at the same time, social prescribing can support that as well. So we realize there's this role called the outreach support worker. So they are essentially doing very similar thing as social prescribing, but they're attached with sorry about background, they're attached with home health teams. So they work directly with community nurses, and they directly work with community case managers. And then they would kind of identify suitable clients, and then it's a house worker, it's an outreach support worker that supports.
Yeah.
So right
asked-
now we know that, yeah, sorry, Alison, go ahead.
Go ahead, finish.
Yeah, sorry. So far, there's only one. And I think that role came from Vancouver Coastal Health, actually. So someone who came from Vancouver Coastal Health tried to introduce that in Fraser Health. And that's what we're trying to promote right now, for every community health offices to have at least one outreach support worker. And they will work complementary with the social prescribing connectors. So the connectors can take care of someone more pre-frail, and then the health authority can take care of someone more frail or any more support.
It's interesting. I asked partly because the language of social prescribing, and you use the trope very well with the little picture of the doctor making a prescription, and that's very powerful for us. But then I guess my question is, because I'm wondering to what extent you think this is being driven, that the interest exists at the ministry in the context of primary care reform, primary health care reform. But your answer suggests to me that maybe in fact it is a broader perspective, because I listened to everything that you've said, and Mariko, I'll look at you, because we're working on a paper about public health, right? It's like, this is a public health care model, not a primary care model. You know what and so anyway, I don't really have a question. And I think in your response, you've kind of addressed some of that. And I find it's gratifying to hear that people are thinking of it beyond the context of the doctor's office, making a link with community, that it really is about understanding healthcare from a community perspective more broadly. There's a lot of potential.
Definitely. Yeah, I think definitely as we roll out, we're realizing instead of primary care, it's much more public health.
Yeah.
And we were working with another partner, and I think they are writing an article exactly on kind of social prescribing and the frailty initiatives on its impact on public health. So hopefully when that comes out, we can share that.
Awesome. That'd be great.
Yeah,
Thank you.
but thank you, Alyssa. And definitely primary care. It started in primary care because we try to advocate this to the doctors in the clinics and etc. And with collaboration with the different divisions of family practice. And interestingly, it didn't go as well. Interestingly, I think because I know you're also trying to kind of engage physicians in primary care, right, for flipping stigma. It was not easy to reach out to the division. We have support from most of the divisions, I would say. But from there on, it's like, what's next? Because I think it's a bit trickier to keep track. Like who actually listened, and if they do come listen, did they actually print out the resource and they start making the referral? So not as much referrals are coming from primary care as we hope. And most of the referrals are coming from community and from the rehab team, from the OTs, the PTs, the social worker. And I guess that is something we can control because we do meet with them frequently and ask for about 15 minutes of their time. So it has worked much better that way. So how do we better engage the primary care team is an ongoing challenge.
Very interesting. Thank you.
Thanks, Alison. Margaret, have you been able to connect with intake teams at community?
Intake teams like
the intake
health service
nurses?
line?
Like for example, Vancouver Coastal Health Community. So Vancouver Community, they have an intake team out of Pacific Spirit, and they have a group of nurses working there, and they often get referrals and calls from members of the public, and often don't make referrals based on whatever the needs are, but they could actually refer people to social prescription depending on what people are asking about. Is that something you've been able to connect with?
Well, outside of the Fraser Health region, I haven't really been able to reach much teams other than through presentations that's provincial wide. So if you do have that contact, Mariko, would love that. I don't think I can personally be the person to advocate it for them because I'm not with Vancouver Coastal. I think that's where a bit of the bureaucracy comes in.
Yeah,
unfortunately. But I can definitely share that connection and do the first initial connection by email with them and the connectors from Vancouver Coastal. And I do have the capacity to teach the connector on how they can showcase this and present this so they can connect with the intake team.
Yeah, I'll see who I can think of. I'm sure Fraser Health is something similar. Also, your transition nurses in hospital too, when folks are getting discharged from hospital, could be identifying along with social workers. But yeah, we should talk some more. We're losing some folks because the evening is going on, but there are a few more questions if that's okay with everyone. There was a really nice question from Paulina Malcolm, and I can't find it now in the chat. Paulina, was it about long-term care? Are you able to ask that question? Because I can't seem to find it in the chat now.
I realized I wrote it and I said SC, but I don't know what I was trying to say. I think I was trying to say SP, social prescribing. But I was wondering about, because I know you said that social prescribing is available for acute care hospitals, but I didn't see long-term care on that list. And I'm sure that has to maybe to do with like funding, you were saying, and the parameters of that. But, and there's a lot of care that's already given to people who are living in long-term care. But as far as from what I've seen is that there's not a lot of connecting people living in care homes outside into the community that's like right around them. And if that does happen, then it's maybe happening with a few people working in the care home, like rec therapists, or like you were saying, maybe OTs, possibly if they really are passionate about their job. But I'm wondering if there's plans in the future, if there was more funding maybe to involve even just the staff at long-term care to connect and collaborate with like social prescriber connectors. And if that's something, yeah.
Yeah, thank you for that question, Paulina. So long-term care, I would say, is not a team that we have actively reached out to. We do have connections to, and they are aware of social prescribing. I think the team we have in connection was physicians and also the nurses in different long-term care sites. So they do know about social prescribing. So is there a reason why we haven't rolled out yes, kind of. I think with our rollout and knowing the connectors capacity, we had to do it very carefully. And so far, other than acute care hospital, with primary care clinics, with virtual care, and the most, I guess, kind of site-like teams is assisted living. So assisted living is actually the first group of teams that we rolled out to, because there actually is, interestingly, a stigma that people in, like you kind of like you said, Paulina, that people in assisted living are assisted already, which is not always true. And oftentimes they are kind of they kind of fall through the gap because people feel like they're assisted because they're already in assisted living, but they're actually not engaged at all in the community. But a lot of times the resources and the program in the community cannot support people in assisted living because they're in assisted living. So a lot of the programs, especially for older adults, has the limitation on has to be community dwelling. Although now we know assisted living is community, but community dwelling, people living in their own home. So yes, they can of course be referred to the connectors, but the connectors are finding kind of bottleneck there when they're referred to them, that they have not much program to refer people to. That said, there are still a lot of referrals from assisted living, not as much as we hope, because the teams and the seniors are finding that, it's not that helpful. There's too many limitations and there's not much resource that suits me. So it's happening, but not as well. So why we haven't gone into long-term care, I think, is exactly like you said, is capacity. So there's only me and my other change lead. So we have to be mindful of how many teams we roll out to, because we don't want an influx of incorrect referral, especially. And we haven't tapped into long-term care more because of the frailty level. Because I think we can't right now, the resource we have can't even support as well for the people who are in the peripheral group or in the community. So we don't feel too comfortable going into long-term care yet, especially knowing that a lot of the resources might have limitation. So it's a tricky balance. Like, we want to tell people about it, but we don't want to give people false hope that it's like, oh, social prescribing is great, it's a perfect program. And then people refer and say, oh, like none of them are for me. That's even much bigger disappointment. So I would say that is why there's no restriction per se, but it's more of how the program has been designed so far and capacity. Yeah.
Thank you. I'm also just wondering really quickly, kind of off of that, maybe like, would there be plans for, are they called social care connectors? Is that why I was saying SCC? I don't know why I was saying SCC.
Seniors Community Connector.
Right, that's the one. But for people like that, and maybe if there's more funding in the future and there's more people like that in the community, for them to maybe not kind of be assigned to someone living in a care home, but at least collaborate with some of the staff. And so that there would be this awareness from the staff, and then they themselves could be kind of referring people within their own care home, or even just on a floor itself, to, like, as a group outing, going to a community center or going to an event or something like that. And so that it could be like, even when there are people that are quite frail, there's still a lot of different things that they can do. I'm just wondering if that would be something, because to kind of streamline like the communication process, just so it's one person.
Yeah, no, for sure. I think that model can be adapted in many different ways. And the one you just described sounds quite amazing. So it can definitely go that way. I think the other thing I would consider is it's not just having the connector, it's also having the other community resources that can support, right? So even if we now have more connectors, which is great and we need that, if they don't have much capacity in their community programs and other resources that they can offer, then it's still not as good as we hope it can be. So I think it's a bit, the more I work and learn about it, it's much more broader. So we can't just say we'll have more connectors and it'll solve all the problems. We do need to recognize all the community resources because they're very tightly connected to each other. But that's a great idea. Thank you.
Thank you.
Hiro, I see you have your camera on. Did you have a question? Nice to see you, Hiro.
Nice to see you too, and thank you so much, Margaret, for the presentation. Yeah, I did have a question, and sorry if you already went over this and I might have just missed it. So I'm wondering about the funding for this program and whether the funding is specifically for the connectors or whether there's funding for the community organizations to kind of to address their capacity as there's more people referred to them.
Thank you for that question, Hito. So it is the funding that we're talking about specifically is just for the social prescribing program. So it's only used on hiring the connector. That said, it's also not standardized. So every connector is actually being paid differently, which is quite unfair because they're also not being paid too much. And some of them are full-time, some of them are part-time. It depends on how the organization uses their money, although it's all for the same program, and whether the organization is unionized or not. So it really varies across the whole province, but it is just for social prescribing for now.
I get see why it's so challenging then to have all these, so many people maybe referred to these community organizations then, and the organizations might not have the funding or support to actually support all the people that they're being referred to. So that makes a lot more sense. Thank you.
Yeah, and the volunteers as well, having volunteers to support those resources or paid positions, which is better.
Sorry, I realized I was muted. I was just saying thanks for your question, Hito, and your answers, Margaret. Any other questions from our group? It's dinner time here, Margaret. That's why we've lost people, not because of your presentation, which was great. Such an interesting topic, but folks are having to run to, feed their families and things like that. I don't see any other questions, just some really nice comments. You probably haven't had time to go through the chat, but Paulina, before she left, saying that it was such an interesting presentation and she really appreciated your answers to your questions. Allison said very thoughtful presentation and question and answer, which I agree as well. It was a very thoughtful presentation, Margaret. Myrna had talked about this idea of reducing healthcare costs, and she called it our brother's keepers to an extent. And I think that's kind of picking up on the idea of collaborating together, and that this may be some ideas of shared responsibilities for one another. I don't know. And let's see, we've got one more question at the end. Oh, thanks, Coral. Excellent presentation from Coral. Lots of food for thought. Yeah, I agree. And maybe that's a good way to end. Thinking about all of these ideas that you've shared with us today, Margaret, and the possibilities that exist when we collaborate together and try to kind of shrink those connections between different areas of care, different types of communities. Anything else you wanted to share, Margaret, before we let you go and start your day off in Japan?
I'm trying have eaten onigiri on my side.
Oh gosh.
For breakfast. I think no, it's amazing, and thank you, Mariko, for inviting me into this discussion. Looking forward to more as well. And I think based on the chat, I think many people would like the pamphlets and the posters and my email. So, and also the volunteer page. So that Richard mentioned. So I'll send all of those to you. Would that be okay? And then you share with everyone.
Absolutely. Now, I don't know if I have everyone's emails because I think some folks found their way here. Richard, do I have your email? Maybe what
Richard has one. I know Richard.
Okay, he does have that. Okay. Yeah, if anyone wants me to email them specifically, I've just included my email in the chat. But yeah, do share those with me and I'll send it out to folks who were here today. Yeah,
sure, I'll do that.
Okay.
Thank you so much.
Oh, you've got it, Richard. Okay, thanks. All right. Well, thanks everyone for taking the time out to join us here. And thank you so much, Margaret, for joining us and sharing what you guys are doing in Fraser Health. We hope this project keeps going and that you continue to spread the word. Enjoy the rest of your day, and to all of you, enjoy the rest of your evening. Take care now. We'll see you next time.
Thank you.